That's a very interesting session that we have today. It's a spotlight session for the day, which is on the healthcare. And the name of the session is Race to the COVID-19 Vaccine and Gearing Up Global Healthcare. And this will be an interactive session. And let me introduce you to the spotlight speakers today. We are joined by the spotlight speaker, Professor Heidi J. Larson, who is the founding director of the Vaccine Confidence Project. She is the professor of anthropology, risk and decision science, Department of Infectious Disease, Epidemiology, London School of Hygiene and Tropical Medicine. Professor Heidi J. Larson is also a clinical professor, Department of Global Health, University of Washington, Seattle, USA, and a guest professor at the University of Antwerp, Belgium. Dr. Larson previously headed global immunization communication at UNICEF, chaired Gavi's advocacy task force, and served on the WHO's SAGE working group on vaccine hesitancy. Professor Larson's research focuses on the analysis of social and political factors that can affect uptake of health interventions and influence policies. Her particular interest is on risk and rumor management, from clinical trials to delivery and building public trust. She served on the FDA Medical Countermeasure Emergency Communication Expert Working Group and is currently principal investigator for a global study on acceptance of vaccination during pregnancy, an EU-funded project on the deployment, acceptance, and compliance of an Ebola vaccine trial in Sierra Leone, and global study on public sentiments and emotions around current and potential measures to contain and treat COVID-19. We warmly welcome you, madam, for joining us today. And our next spotlight speaker is Mr. JVR Prasada Rao, who is the former Health Secretary, Government of India. He's also the former Special Envoy on AIDS for Asia Pacific, United Nations. He's also a member of the National Task Force of ICMR for the COVID-19 response team. And Mr. Prasada Rao has served as the director of the National AIDS Control Organization and has been the additional secretary in the Ministry of Health and Family Welfare from 1997 to 2002 to head the national response to a raging AIDS epidemic in the country. He also led the organization in an unprecedented response to AIDS with multi-stakeholder involvement. From 2002 to 2004, he served as the secretary in the Health and Family Welfare Ministry and was instrumental in bringing out a national health policy and a national AIDS control policy in 2002. Subsequently, he was the regional director for Asia Pacific region of UNAIDS at Bangkok, the joint UN program for control of AIDS from 2004 to 2009. During those 5 years, he led the UN response to AIDS in Asia Pacific countries using his experience from India's national program, the largest in the region. After his return to India, Mr. Rao was appointed as the Special Envoy on AIDS for Asia Pacific region by the Secretary General, United Nations. He interacted closely with political leaders, including presidents and prime ministers of countries in the region, for prioritizing AIDS control in the national plans and strategies. Mr. Rao is currently involved in COVID-19 response in India as a member of the National Task Force of ICMR and is on the Global Advisory Board of the State Government of West Bengal. We warmly welcome you, sir, for joining us today. And this session will be hosted by esteemed chairperson, Dr. Kunal Sarkar, who is the Senior Vice Chairman, Director and Head of Cardiac Surgery, Medica Super Specialty Hospital. Dr. Sarkar is a renowned coronary surgeon and is intimately associated with the academic activities of European Association for Cardiothoracic Surgery and Indian Association of Cardiovascular and Thoracic Surgeons. He has also been the past president of IACS. He also aspires to bring the South Asian nations together in the South Asian Forum of Cardiothoracic Surgeons. A passionate debater, orator, and writer, Dr. Sarkar is the president of the Calcutta Debating Circle and chairs the largest live debate in India during the Calcutta's Festival of the Spoken Word. He is also the chairman of Kolkata Heart Foundation. Dr. Sarkar graduated from Medical College, Calcutta with gold medal in surgery and won 12 other awards in surgery. He's trained in cardiac surgery in Cardiothoracic Center, Liverpool, St. Mary's Hospital, UK. He is also a fellow of Royal College of Surgeons, Edinburgh and Glasgow, and a faculty of Imperial College, London. A warm welcome to you, Dr. Kunal Sarkar. And before I hand over the session to you, ladies and gentlemen, there's a Q&A box in case you have questions for the spotlight speakers and for the chairperson, kindly post them in the Q&A box, and we will get to them at the end of the session. And I now hand over the session to you, the spotlight session for the second day of INFOCOM, which is the race to the COVID-19 vaccine and gearing up global healthcare. Over to you, Dr. Sarkar.
Okay, thank you very much. Am I audible? You are.
Yes, sir.
A very good afternoon to Professor Larson. Good afternoon from India, and Mr. Prasada. And thanks to INFOCOM for giving me the opportunity. Thanks for asking. And I'm full of sympathy for Professor Larson and Mr. Prasada, who for the good part of next half an hour has to be in conversation with a stupid cardiac surgeon, right? Very accomplished as they are. You see, one disadvantage of the virtual platform is that you do not see the board audience nodding off at the other end. So I think, we'll try to keep ourselves fairly sharp, topical, and brief, and on a very interesting topic as the mantle given to us by INFOCOM. So Professor Larson and Mr. Rao, I don't know whether it has been purely coincidental or partly planned that we have been brought to this session at a day, 48 hours from which, Britain hoisted the world leadership in sanctioning the vaccine, and probably the first instance of Britain hoisting world leadership after D-Day in 1944. Well done, because everybody was hesitating and trying to push the other person to the front of the queue. You go first, you go first. And who else but Boris Johnson takes the leap of faith first of all. But having done that, I think that has been a big breakthrough. Professor Larson, having gone through, having gone through the 10 months of this pandemic, it is believed that if all the viruses of the world were put together, it would be less than 2 grams in weight. And yet, this 2 grams weight of virus has inflicted a lot of misery on 65 million people with a mortality of more than 1.5 million. Now, were you satisfied? Were you skeptical with the overall global response to the pandemic control so far? Because we have these contrasting experiences in the world. We have Southeast Asia, which has stood up very gallantly. We have rest of the world, which seems to be completely caught off guard. So why do you think we had such a contrast in responses between like 1/3 of the world's population and the rest 2/3 who were almost sort of caught napping? I mean, why do you think we had this kind of disparity? And especially I think you witnessed a lot of it from Europe. So your perspective, please, Professor Larson.
Well, in terms of being caught off guard, I think that caught off guard or not paying attention, I think is one way to look at it. I think that, particularly we had a pandemic in 2009 of H1N1. That did not turn out to be it was bad, particularly in age groups that we weren't expecting. But it was not as bad as we had feared, because it was the same strain of a virus that was the 1918 horrible global pandemic. But it did re-spark in the global community a lot of discussion about we need to be prepared for the next big one. Then again, when Ebola hit, again, it was another reminder. So there's been a lot of discussions about preparedness. But somehow, as you rightly say, the COVID pandemic, I think in some ways, we weren't expecting it to be a coronavirus. Even though SARS started to suggest something, but it didn't get so much traction. But I do think that we could have been better prepared as a planet, but I also don't think that people were expecting, for instance, that Italy a ski resort would erupt with the same virus as Wuhan. Why didn't other countries along the way? And some of this was just the nature of the virus, and they do think that there was a particular strain that became kind of hyper-infectious. It does remind us that the world, how connected the world is. And I think some of it is because of politics in terms of the levels of preparedness, but the nature of the virus also has unraveled surprises.
You're absolutely, you're so right in your observations. But, a funny part of the story is that almost every country who shares a land border with China did very well, and everyone else who was connected by air did miserably, right? So every country, the closest countries to China, to Wuhan, did admirably well as far as the pandemic control was concerned. We move over for the response from Mr. Rao. Mr. Rao, with your vast repository of experience in healthcare administration with HIV/AIDS. I'm of a generation when we were working. It happened to be in London in that era. We were thrown at the rough end, of the HIV patients, and it was all very scary at that age. But thankfully, it gradually kind of died down. So, how would you, frankly, I'm sure we haven't got much of the governmental people watching. I mean, so far, how would you rate India's response to the pandemic control? I mean, were you satisfied or weren't you?
Yeah, I think India's response is mixed, I would say. It is not totally disappointing, at the same time, totally exemplary. Otherwise, we wouldn't have had so many millions of infections in the country. I think India started well. I think the initial preparedness was good, and we have closed the airspace and then introduced travel restrictions and also screening at the airports and other entry points. So in the initial stage, it was good. But the prolonged lockdown that was imposed was also necessary at that period of time. But I think we should have got a little more notice. The people should have got a little more notice that a lockdown is coming, is impending. Without that, I think we got into problems which are not directly related to COVID, but which are associated, like the huge migration problem. So the government's attention went into tackling the migration problem more than the COVID problem at some point of time. I think that's where probably we lost the opportunity to control it at a relatively low level. And then you have the story of the migrants going to their home states and they are coming back with the virus, infecting the states where they are working. So it went into the open. But when it moved from a concentrated epidemic to a community transmission, there should have been greater acceptance of that reality at every level, both the government of India as well as state governments. See, it is always better to accept and then own it than just denying it and moving forward. So I think that's where probably we made a tactical error, I would say. We could have said, yes, it is already in the community, out in the open, so we should be more careful. So the strategy also needs to shift from a screening and and then testing to a more open testing policy, and also to introducing voluntary testing also, so that people can go and get tested. So there should be having a paradigm shift in the entire approach at some point of time, maybe in May or June. That would have probably reduced the number of infections. I mean, in hindsight you can say this, but I think if you look at the fatality rate, I think India did extremely well in keeping it very low. So I think compared to other countries, I think in India the fatality rate is very low. And also the recovery rate has climbed up and is very high now. So in these two, I think we have done fairly well. So it's a mixed performance, I would say.
Very, 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 very sharp observations, Mr. Rao. If I may ask you one question, I have nothing against bureaucrats, but it is said very often that India's response has been very dominated by bureaucrats and politicians, so much so that 10th month into the epidemic, we still do not know who India's chief epidemiologist is. Does it not surprise you?
Well, I don't know, because if you look at who is leading the response at the government of India level, it is not the bureaucrats, it is the ICMR. the Indian Council of Medical Research, which you will find are giving their regular press briefings, and they are the ones who are laying the policy. They are the ones who are prescribing the testing policy. So it's not the bureaucrats only. I think it is the.
Can I just interrupt you? Can I just interrupt you, Mr. Rao? Because I mean, honestly, being connected with healthcare, I find it a little bit bizarre that how did a research organization get muddled up in a purely clinical public health problem?
Absolutely. I think this is exactly what I.
We had a center.
This is exactly what I wanted to learn from you.
We had a center for disease control in Pune, right? The Centre for Disease Control in Pune seemed to have shut shop. And the entire baby with the bathwater fell onto the laps of ICMR, which are very knowledgeable, very erudite people. But what were they doing in the public health domain? They are researching.
Absolutely. Absolutely. You are right on the spot there, Dr. Sarkar. The response part should have been with the National Institute of Disease Control, which is the NIDC, which actually has the repository of all information. They are the ones who run the IDSP, the Integrated Disease Surveillance Program. They have all the information. I, for one, expected, because when I was health secretary, that was the time IDSP came into existence. So I was expecting that IDSP is the one which will take over the response at that point of time. But somehow or the other, the ICMR came into the picture, and then ICMR is the one which was looking at testing kits and also about screening, all the issues, all the concerned issues relating to COVID response. Why it is happening, I don't know, because I have no idea why ICMR is the one which was chosen by the government, maybe for some valid reason. But it would have been better if the epidemiologists are the ones who would have taken control of actually tracking the epidemic, looking at the response, making mid-course corrections. This should have been the work of an epidemiologist and a public health expert. Basically, I agree with you on that.
Professor Larson, I just want to provoke the anthropology side of you. That do you really, are you convinced with this sort of species violation theory of COVID-19 so far, that it was actually a species the jumping of the virus, the zoonosis spreads from one species to the other? Do you think this hypothesis that was probably propagated and sold to the world from the University of Shanghai, the Chinese bat woman professor and the rest of it, are you reasonably academically convinced with that argument?
That this is naturally derived from animals?
Yes.
Well, I mean, pretty much many viruses do come from animals, and all of our evidence so far, it seems pretty clear that it's from that. I mean, it's not to say these things can't be manipulated, but there is quite extensive investigations into that, and we see no reason not to believe that so far. There's no strong evidence to say otherwise, is what I'm trying to say.
And before we move on to the other issues, so from that point of view, we've had this experience in 1918. We've had it experienced God knows how many times in history, starting from the Peloponnesian War and the other things, when we've had these zoonotic kind of spreads and diseases. So what would be the lesson? Do we all forget these lessons in the next century to come and get on with life as we know it? Then from this kind of thing happening as a zoonotic spread, a species jump, a violation, what lesson, Professor, do we take home from this? What not to do in future to provoke episodes and incidents like this?
Well, I think we're not going to be able to stop the jumping. I mean, it's a process that's continually evolving, but I do think that.
Because, sorry to interrupt. All I mean to say is happened n number of times before. It keeps on happening. And it's almost with ominous regularity, every century we succumb to this. So what's the lesson? Yeah.
The lesson is it keeps happening, so we need to be better prepared.
That's it. It will happen again.
But it doesn't keep happening in the same way. And
Right.
so on the one hand, we need to be better prepared because there's a certain amount we can control and there's a certain amount that we can't control. Some of it is also to do to climate change and the pushing and population growth and how the interface of humans and animals is getting a lot more pressure. That's for sure. And there's a lot of environmental contextual issues that are putting pressures on that relationship. But from the public and global health perspective, we need to be better prepared. We shouldn't be caught off guard, seemingly in some ways the way some people seem to be with this one. But also we have to recognize that not all the lessons from the past are going to be relevant each time. We have a totally different situation now than we did, not just since 1918, but since 2009. The whole digital communications landscape has made this much more complicated. It's, on the one hand, could have been an incredible resource for sharing good information, but it's caused huge complications in terms of misinformation, for instance. And I can promise you by the next pandemic, whenever that may be, there will be other things going on, other things complicating it. Armenia, they had an outbreak of COVID and then had an earthquake. You know, you can have a political conflict, you can have other things happening. So we need a different kind of resilience.
Professor, before we move on to other topics, I would request you for a minute or so. I think this is something a lot of the, this kind of lay audience does not appreciate. If you can explain to people the impact of climate change and how the human-animal interface is getting stressed, that's something very important that you just said to us.
Well, let's take Ebola, for instance.
Yeah.
In West Africa. Ebola has been in Africa for, we've known of it for 40 years. Well, 1976, it was first documented. It was likely there well before. But the reason that the West Africa outbreak was so dramatic and of concern is that those previous outbreaks had been in remote kind of equatorial areas that were contained and it put out the spread. What happened in West Africa was a perfect storm of deforestation, of trees being cut down, of bats moving more into urban areas, looking for food, looking for population congestion because of rural jobs and whatever, not being as some of the agrarian, more people moving to the cities for jobs. So more people, more animals, deforestation, and that whole interaction accelerated what was normally a more containable spread. That's just one example. So it's a mix of environmental issues pushing people into more urban areas getting more congested, pollution complicating it. And then, with that, animals also need new places to harbor, and that's where it gets complicated.
Thanks, Professor. Very well explained. Mr. Rao, I cannot resist the temptation of borrowing from your experience with the AIDS prevention. I think, because we were sort of clinically involved in that process, though I think we were largely uninformed in an era, the era of the mid-80s and the early 80s, there was no internet. You were only dependent on the print and the conventional media for the news of these spreads to go on. What kind of parallel do you draw from your HIV experience to what you see, what you witness is happening around us in COVID-19?
I think there are a number of common characteristics and a number of differences also between the two. The common ones are the extreme level of denial that we saw in the AIDS epidemic. You also saw it in COVID initial stages in a number of countries. And that's where I think countries missed the opportunity of containing it at an early stage. thinking that it doesn't happen there. It is a Chinese virus, so it'll remain. If you can just restrict the people coming from China and test them, that is enough. So that is one. Second is the level of denial was really very, very evident in many countries. But the big difference is that in the case of AIDS, the real special feature is the community participation. At every level, right from the beginning, the communities which are affected by AIDS and who are infected, the people living with HIV/AIDS, the gay population, the sex workers, the drug users, they were all involved in the whole response right from the beginning. Some on the other, in COVID, you'll find the entire approach, not only in India, in many countries, it is totally top-down. It is just somebody sitting at the top dictating something and then others trying to follow that. I didn't see any community involvement at any level in the COVID response, not only in India, in many countries. That is a striking contrast between the two. Maybe one reason why we have not been able to restrict the number of infections at a pretty early stage, because people were not involved. It is entirely the government functionaries, the police. These are the people who are mostly trying to work with the program. But you hardly find any NGOs, any community organizations coming in and trying to work in close contact with the government.
Thank you, Mr. Rao. But I think there is one trait of commonality between the two. That is, for the good part of the first response, the clinical medicine was equally helpless in both these things. For HIV, thankfully, the transmissibility was low. But I've been inside both HIV wards and the COVID patients. But still today, apart from isolation and oxygen, everything else is hypothetical. So, but fortunately, that helplessness of clinical medicine has been a little bit lifted from the good news from the vaccine area. Right. So I think what the doctors really, we carry a little burden of guilt on us, that what the applied pharmaceuticals and the physicians, we stumbled in finding an appropriate antiviral. We've never done very well with antivirals anyway. So we stumbled with the antivirals, but fortunately, there is a little bit of a dark clouds lifting with the news coming from the vaccine area. So Professor Larson, we have seen, by all accounts, a kind of a lightning speed on the vaccine domain, the work going on in 10 months from the University of Thailand and the University of Shanghai, isolating this virus somewhere in the 12th of January to you have a vaccine in somewhere within 10 months or so. It is said, that things have been fast, but the scientific processes have not been compromised. What the pro-vaccine people say is that, yes, we've been very rapid, but we've not compromised on the scientific nitty-gritties of the process. Do you agree with that?
I do agree with that, to the extent that we've had time to be doing the safety work. I think the public is correct that we have not had these vaccines long enough to see some of the potential long-term rare events that happen, but that's true with introducing any new vaccine. But the processes so far have been absolute rigor when it's come to safety. It is other pieces of the process that have been shortened. We have new technologies we've never had before. We were able to characterize the virus much more quickly. We had funding mechanisms that we didn't have before, thanks to Ebola, that woke up the global community to say, we don't have emergency rapid release funds for research. We need that. So CEPI, the Coalition for Epidemic Preparedness and Innovation, was established. India was a key partner in that. And that has been a tremendous boon to allow things to happen more quickly. But safety, as far as the trials have gone so far, has not been compromised.
What would you say, Professor Larson, on the aspect of international scientific collaboration? Were people competing with one another, or were they collaborating with one another? Briefly, there was a little bit of a banter between the Oxford group and the Russians, saying that, they were sniffing at one another's data. But that apart, we can excuse Vladimir Putin for that little bit of transgression. But that apart, did you see a good amount of, did we see, I'm not taking the answer for granted, did we see a good amount of scientific international collaboration this time?
Absolutely. We couldn't be this far without the global collaboration. I mean, all of these trials are global. I mean, even the Chinese vaccine has trials in Indonesia, in Brazil. Oxford has trials in Brazil. And actually, it's not Oxford, there's just Oxford even. I mean, the AstraZeneca vaccines, I mean, these trials are in multiple countries with multiple teams. It's been a hugely collaborative global effort. I think, different countries, different political leaders have tried to move forward. I mean, as you introduced the session and congratulated the UK for the first approval, but they weren't approving the one they were expecting to approve.
Sure.
It wasn't the Oxford vaccine. It was the Pfizer BioNTech one, which is made in Belgium, and BioNTech is a German company. And I mean, it's ironically, it wasn't the one they were expecting to approve first. So politicians, I think, want to take, be ahead of the curve. But I think at a scientific collaboration level, it's actually been an incredibly collaborative. And each of these vaccines are a bit different. They will be, used differently. They have different logistical issues. Some are more appropriate for some settings. So I think that we should celebrate the scientific progress and collaboration to date.
We certainly should. We certainly should, Professor Larson. But on a lighter note, do you think this is the first advantage of Brexit that you have seen? Because otherwise you would be stuck for another month with the European Union. They're not meeting till the end of December to approve to have their approval committee meetings. So are you happy that you've been in Brexit so far? Because otherwise Britain would be hanging around for another month and a half for the vaccine.
Well, I'm happy to hang on to Europe. Let's put it that way.
But Europe's will probably not before another 6 weeks or so. They'll take to go through their approval regulatory mechanisms.
Well, that's very different. That's not the same. The EMA approval is a very different level of approval.
Right.
And it will be approval for authorization. I mean, I think that's an important point you raised, because people shouldn't see the two as the same. It'll certainly have bigger implications, the EMA one.
Yeah, otherwise it'll be a bit funny to see Britain using a vaccine made in Belgium 6 weeks before the Belgians get to use it. So that would definitely be a bit funny.
I think the Belgians are happy to wait for the EMA approval.
Mr. Rao, I mean, somewhere, as you said earlier on, that we could have avoided certain things like the migration and the rest of it. But there was a little bit of a shift from the central government in India trying to possess, being the big brother of the control campaign, to last 3 months or so, it's been like 30 states of India has had 31 different versions of the pandemic control. So I'm sure we don't want that to happen for the process of vaccination. The Prime Minister today has given us some very positive notes about vaccination, but we really want, more kind of collaboration, more sort of systematic approach, a bit more of science, a bit less of, political wranglings. How do you see? I mean, are you a little bit fearful? Because I am, that the process of vaccinating, say, 120 crore people we may fall into the same trap again.
No, you're right. It is an unprecedented and challenging job. Let's not have any misgivings about it. But I think we have to learn lessons here. And the government of India has certain allotted functions here. But at the same time, when there are state governments, there will be definitely different levels of response, different types of response. In a federal setup, you can't avoid it. It can't be one uniform pattern everywhere like what will happen in China or somewhere else. So there is going to be difference. But there are certain things that government of India need to make it very clear. That is, which are the vaccines which are going to be selected. That has to be a scientific work, I would say. It is the work of scientists. They have to tell us which are the most efficacious vaccines. And also you have to look at how much are they affordable. For example, if you have a vaccine which has to be stored at minus 70 degrees centigrade, do you think that is the right vaccine for India? Can we have a cold chain which can take that sort of a challenge? So these are issues which need to be dealt with, but that has to be done at the central level. I completely agree with you. We need to have a uniform policy on that. And also fixing the price at which you are going to buy the vaccine. If each state government starts negotiating the price, it will set up a rat race among the states. So that's not going to be helpful. So, but the implementation part, the execution part, that you have to leave it to the states. You can't be dictating that sitting in Delhi saying this is how you are going to vaccine. Which are the groups you have to vaccine? Which are the priority groups? How are you going to identify the priority groups? How are you going to approach them? Which are the vaccination teams which will be going? How the capacity will be developed among them? All this nitty-gritty, I don't think somebody can sit in Delhi and prescribe it. That has to be left to the state governments. They have technical experts, they know the country, they know the people, so they are the ones who have to decide. It has to be a mix of Government of India laying down certain criteria, certain policy guidelines, etc., and the state governments implementing them to the best of their ability. It has to be a mix of both. It can't be this or either this or that. That's how I put it.
Yeah, can I just ask you a little bit more of a specific question? Because you see, as Professor Larson said, that Britain did not approve the vaccine it was expecting to approve. It ended up with the Pfizer. Similarly, in India, honestly, with AstraZeneca getting their mathematics a little bit, topsy-turvy with the half dose and the full dose and that kind of problem. You see, at the moment, we are not holding any vaccines in our hand till we get into the approval process, right? So that is one aspect. But being a very experienced healthcare administrator and thinker, how do you see the process? Because my understanding in India is like healthcare. We have a bit in government and a bit in and a big bit in private. That probably there will be two parallel mechanisms of vaccination. There will be a state-like vaccination machinery, and probably once you have full approval, some of it will also be available in retail for people to buy it off the shelf and use it. Is that your reading of the situation as well, or I'm wrong?
No, I think under the universal immunization program, every Indian citizen is eligible to get vaccinated. That is what the Prime Minister has promised. He said every citizen will get the vaccine.
So why are we discussing two prices? Like for Oxford, we are discussing 250 rupees and 1,000 rupees.
But yesterday you had the Health Secretary and the DG ICMR saying that only 50% of the people will be vaccinated. The other 50% are supposed to get immunized. I don't understand this. Because who are those 50% who will be left out? Invariably, what happens is the people who have the least access, the people who are the most, I would say, hard to reach people, or the poor people, they are the ones who will be left out in the process. You see, that's why I find this argument very inconvenient, saying that if you give vaccination to 50% of the people, the other 50% will be automatically immunized, or they will develop herd immunity. Because basically, you need to get into a situation where people of this country are entitled to get vaccines. But if somebody wants to jump the queue, somebody wants to get it tomorrow, you can go to a private sector and buy at a higher price and get vaccinated. That parallel stream can be made available. But the thing is, it is government's responsibility to take up vaccination on a universal scale. You can have prioritization. You can vaccinate the healthcare workers first, then the elderly people, then the people with comorbidities. You have a list of priorities, but it has to reach everybody. It has to reach the last mile. It has to reach the people who otherwise don't have access to vaccines. If you limit it to only certain percentage of population, I think we'll be getting into a situation where people there'll be absolutely a craze to jump into the bandwagon. There'll be a crazy scenario, absolutely. Everybody trying to get into that 50% because they don't want to be left out. So I'm not able to understand the logic behind this, leaving 50% out to develop herd immunity.
Mr. Rao, it's not just the logic. I am also not able to understand the numbers because according to the last census, India has a total healthcare workforce strength of around, say, 25 lakhs or 30 lakhs, And today the health secretary quoted a figure of 3 crores, which is about 2% of India's population. There is no country where 2% of population works in healthcare. So I believe, what you said, that there will be a lot of VIP culture seeping into the entitlement, the VIP entitlement, because this figure that was quoted today is a little bit out of tune. It doesn't seem right. You definitely don't have 3 crore people in India involved in healthcare, not by any stretch of imagination. It's not possible. Anyway, let's hope for the best and see how the story evolves. Right. In many of us in India, in our kind of situation, we don't appreciate, how significant a problem vaccine resistance, or say what you call the anti-vaxxers are. It's said that in America, in the United States, it's a big issue. It's a big time problem. So between China, which has a vaccine resistance, it's claimed less than 5%. United States, it is claimed has a vaccine resistance of more than 50%, more than half the population. Where does Europe and where does UK stand? And is that a big problem? Do you envisage that being a big issue?
It's more of a problem in the UK. We run a lot of surveys on willingness and intent. The UK, 54% said that they would take the vaccine. I think the countries that are the most least willing are France, Hungary, Poland, Russia. So Europe is, interestingly, the most vaccine skeptical region in the world based on our 5-year analysis, and that has stayed that way. It's gone up a little bit. In all of our COVID vaccine intention studies, interestingly, India and China are the most confident about taking a vaccine, or at least that's what they're saying. Let's see when they have it.
Perhaps we are the most desperate at this point of time.
Actually, I think, there are a number of Indian companies that are very engaged in the COVID vaccine work, which is fantastic. Yeah.
But how do you intend getting around the problem? Because the ultimate belief that it immunizes the population and it showers in a kind of herd immunity. But if you have 40% or say half the population not immunized, wouldn't it be a bit of a defeated exercise? How would you get around the problem?
Well, I think that these surveys are about, it's very different to do surveys on vaccine confidence in a stable setting with vaccines are familiar and known. Around the COVID one, there is tremendous uncertainty. I think it's not unreasonable for people to be unsure whether they want to take it. So, and also what we've seen is in those surveys is that people's sentiments around whether they would take the vaccine have been changing. Every month they're changing since April, May until now. And
why is that so? Why is that so? Why does it change?
Totally reflective of the state in their country of the pandemic.
Oh, right.
So if they feel the threat, their willingness is a bit higher. If they're starting to feel a bit like, well, I got through this, they're less willing to take the vaccine. The surge is back and they're like, well, maybe I would take it. And I think when we actually have the vaccines will partly depend on how much people feel like they're still threatened by the disease, as well as who else is taking it. Because people want to see, I'm going to take it after he takes it.
Two quick questions for you. One is that on the sort of whispers or on the grapevine front, we are sort of hearing good things about the Imperial College Johnson & Johnson work on the single dose vaccine. What are your impressions? Because I think they are probably hitting stage 2 now, because that's the only single dose vaccine so far. Because have you heard good news on that front? Because I'm
very enthusiastic about this vaccine candidate. I'm really looking forward to its moving ahead. I've got my eye on that one.
Yeah, but, because so far it's the only single dose one, and it's not just the rivalry with the Oxford group, but it's supposed it's supposed to be clever. It's supposed to be clever stuff.
Very clever.
It's supposed to be very clever stuff. It's a single dose vaccine, coming up so far. I think that would definitely make a lot of. And if you were to hazard a guess, with vaccination starting, say in England, in Europe, by the middle or end of December, can we sort of expect for a normality, whatever it means, if normality meant January 2020, do we see January 2021 or the autumn of 2021, not January 2021, or say by autumn of 2021, we getting back to our bad old ways or travel, work, etc.? Is that scenario envisaged? Is that practical?
Getting back to, well, it depends on the country and what stage you are. I mean, for us at the London School of Hygiene and Tropical Medicine, we never stopped working, but the nature of our work has allowed us more to be able to work at home. Our lab people have had to go in just because you can't take care of your lab from home, but that's already a very controlled environment and spaced. But I think we need to, everybody's trying to get back to, we're never going to get back to the normal we were. We can forget about that. And maybe that's not a bad thing. I think we've all been rethinking our futures personally, collectively, politically through this time. And all I can hope is that we really think seriously about how we can make the world better post-COVID.
That's very well put. That's very well put. Mr. Rao, right? Again, drawing on your huge reserves of experience with healthcare. You see, I don't know, it is believed that, say, in India, our capacity for vaccination so far has been about 15 to 16 lakhs a month. And that is mostly with non-injectable vaccines, mostly with oral polio, not really to do with adults, etc. So what would be your advice? How would the healthcare administration, the primary health mechanism, because we really have to step on the accelerator. At 16 lakhs a month, it takes us something like 6 years to vaccinate India. So that is impractical. So what would be your advice so far? How do we tighten up our action, put our foot on the accelerator, so at least within a year, most of the year or 18 months, most of the target population vaccination is achieved? Is that possible?
Yeah, it's possible, provided we have advanced preparation for it, because it's a huge challenge. Till now in India, immunization program is mostly restricted to children and maybe a little bit on mothers. And our entire cold chain capacity is only about 80 million to 100 million, that's it, doses. So you need at least 10 times more capacity than that if you really want to handle this load of vaccinating people with COVID vaccine. So a lot of advanced preparation on many fronts are needed. First of all, the entire cold chain you need to augment. Second is you need to have a bunch of vaccinators, a whole army of vaccinators who need to be trained in vaccination, and then fan them out into the villages, into the remote corners of the country. You need to train them. You need to make the people prepared. For example, many people still have many misgivings about the COVID vaccine. I have seen this resistance to vaccination when we were dealing with the polio eradication program. There is organized resistance against polio vaccination at the time. So there will be now also. So we have to foresee those situations to make people aware of the importance of getting vaccinated. So a number of preparatory steps from now onwards need to be taken. I think they're already on the job, both the government of India and the state governments. But I think we need to put it more in public domain. People should know more about what the governments are doing, both the government of India as well as the states. I think that is the most important part.
I mean, Mr. Rao, what does your sources tell you? Is any of that happening?
Yes, it is happening, but may not be to the required scale, but it is happening.
Because another challenge you see is the double dose vaccination. That's a big thing for India. That you give a lot of first doses and miss out on the second doses, that would be an entire waste, because
absolutely.
I hope we don't come to that. We seriously hope we don't come to that. I think, as you said very correctly, sir. And could I now put the crystal ball in your hand and tell you that, drawing again on your knowledge and experience, how do you see us 6 months from now? Do you see a quasi-normality? Do you see 50% normality? Or do you see that some of the turbulence will still continue?
I think it will continue. I don't see any possibility of a near normality in the next 6 months or even 1 year. And even after that, I think we need to do our business a little differently than what it was. As Heidi has said, I don't think we are going back to the old normal. If somebody is seeing a dream of the old normal, forget about it. It's not going to happen. You are going to get into a new normal where working from home, working in a different way, and then wearing a mask when you go out, when you have a cold or a fever. These are some of the new things which need to come. You asked one question about Southeast Asia. There is a cultural aspect there. See, in Japan or Korea or Thailand, etc., you find people when they has a cold or a fever, they even otherwise they wear a mask. That is a part of their culture. I think it needs to come into India also. Public hygiene, personal hygiene, wearing a mask, caring about the others. These are not the part of the new normal, and that has to come in. If we think that we can just forget about everything and go back to the old normal, I think that's a big mistake we'll be making actually.
I think very, very well said, Mr. Rao. Probably what we expect to see, I'm sure you know, that one of the habits that we have adopted in the last 7 or 8 months, probably, not only with COVID, it will probably reduce the incidence of tuberculosis in India significantly over the next 2 to 3 years to come. There will be a lot of collateral benefits. The tuberculosis, childhood respiratory problems. I'm sure, the virus, along with a lot of sadness and misery, will bring some benefits to us. I think, it's been wonderful speaking to you. And I'm sure, like the entire audience, I at least have learned a lot. And should Rakhi have some questions lined up for us, I think you can certainly shoot away. Yeah, thank you.
Yes, sir. So the first question is, will we, if the vaccine comes out, will one vaccine work for everybody, or will we need to take a combination of vaccines? How will that work out?
Who do you want to answer this?
So you can choose Professor Larson, probably.
Yes.
Well, I think it's going to depend on a lot of factors. I think one, you have to see which ones the government approves. It'll probably be multiple ones. It's going to depend. There are very different logistical requirements for these different vaccines. The mRNA ones, for instance, need kind of freezer cold, deep freeze refrigeration, -70, 80 degrees. That's not going to be great for a number of the locations. In India, for instance, you want a more stable vaccine. So it's going to be a mix of what's available, what's appropriate for the situation, where you have the capacity, and where your priority population needs are. So it's going to need to be a mix. And the more vaccine options we have, that's a good thing to the extent that you can accommodate, because each one's going to take different training.
Raki, if I can just add a line to this. You see, in the Indian context, India is aiming for about 40 crore or 400 million vaccine doses by June or July. There is no way one company will supply us with 400 million. So it will probably be something like 50, 30, 20, 50 being Serum Institute, 30 being Hyderabad, our co-vaccine, and there has to be a 20 somewhere else, maybe Zydus or somebody else coming in. And that will give us 40 crore doses, which only means 20 crore Indians being vaccinated. Because it is 2:1. If you have 40 crore doses, you don't have 40 crore. If you have 400 million doses, you don't have 400 million vaccines. You end up vaccinating till July about a population of 200 million in India, which is less than a fifth. Yeah. So that is the scenario. So, but this is not like having different ice creams. So we must not take a first dose of Oxford and go on to have a second dose of Hyderabad. So if you do that, internationalism will be in a lot of trouble. So if you with Hyderabad one, stick with Hyderabad. So one Hyderabad and one Ahmedabad will not work very well. they are by nature.
Absolutely.
Yeah.
So the next question is from Mr. D.D. Purkasta. He's saying that, it usually takes a vaccine at least 1 or 2 decades to develop. So even if the vaccine comes in, 10 months, do you think it will be safe and acceptable? How do we have the assurance that it is going to be okay?
I think Professor Larson referred to it. She can probably underline that again. Yes. Yeah.
Well, I mean, I think that, as I said before, the different aspects of the vaccine development were shortened, but not the safety. I mean, we do need to, there are, long-term future rare things that we need to keep an eye on, any possibility of, but everything so far has been strictly followed.
All right. Ma'am, there's another question for you. It says, this is from Mr. Iman Ghosh. He's saying both the EU and Dr. Fauci have criticized the speed at which the UK has approved a vaccine from abroad. And the EU's criticism has been that the emergency provision approval clause was not meant for individual cases and not vaccine groups. Do you have any comments?
Well, as I said earlier, this is a different kind of approval process than EMA or FDA would give. They will be doing a more rigorous type of approval that will allow for authorization of the vaccines. This is just a small, an initial one that it'll still need another level.
I'll just add a comment to that question, because again, I don't want to stir an international row on this, but the trouble is, you see, US suffers from the same disease as India because we are struggling with 30 states, they are struggling with 50 states, right? So there is that much of fragmented approach to anything, to any public health measure, that honestly speaking, they're going to have a lot of problems. So I, for once, I'm no great fan of Boris Johnson, even though he spoke in one of our debates. But having said that, I think UK has really taken a considered approach, and that was the way forward. And there is nothing scientifically suspect with what UK has done so far. So it's been very sensible, actually.
The next question is from Mr. Shubhama Chakraborty. He's asking, is the vaccine discovery connected to any previous work that was being carried out for, say, from the SARS time, or is this a fresh discovery? Professor Larson, would you like to take that?
If which one is a fresh discovery?
I think he means in general. He's saying that.
All of these vaccines, I mean, that's actually an important point. Even though this particular focus on the COVID-19 has been shorter, these are platforms like the mRNA platform. There has been a lot of work on the development of this platform. This is not brand new in terms of the development process. It hasn't been used for vaccines yet, but the actual principle and the research into this platform has really a lot of substantial development before now. Similarly, with the other virus, the other approaches, they've all been in different ways to use before. So it's not like they started yesterday in this case.
You see, if you consider the AstraZeneca vaccine, the Oxford vaccine, I think half the work was already done during the Ebola platform, right? The adenovector module, which Kamalaya, the Moscow Russian vaccine, and Oxford too, half the work was already done in the Ebola. So they, in some scientifically speaking, they continued from that. And what we are doing in Hyderabad, you see, very clever work, co-vaccine. Co-vaccine is perhaps the only live attenuated virus, which is not very different from what happened 50 years ago for the polio vaccine, right?
Yeah.
So from the days of Sabin and Salk and all that kind of things. So nothing starts, science is a continuum. So you go on following on. So some of it changes, obviously new technology is important, but many of it is continuity of the work that has happened before.
Every time you don't go back to the drawing board.
Exactly, yes. So true, so true.
Okay, the next question is, there's possibly so far maybe one Nobel for vaccine discovery for yellow fever, I think. And do you think that if this vaccine comes out, it will get a Nobel Prize?
Hypothetical.
I think why not? I think my answer would be why not? Well deserved.
I would reserve the Nobel Prize for somebody who gets a vaccine for HIV. It is evading you for the last 40 years. And I think this is really a challenge to the scientific community of the world, that why we are living with HIV virus, even 40 years after discovery. Why we are not able to get a vaccine? Why we are not investing enough on vaccine research for HIV? I mean, that's something which beats my imagination.
Very true, absolutely.
A lot of questions, sir. A couple more. There's one question for you, Dr. Sarkar. There's a question from Mr. Kaustav Sinha, who's asking that will this vaccine be given to people, those who are COVID affected and already recovered? If yes, then what will be the priority? Will they get it first, or they will be, they'll have to wait?
Well, the good part of the bad news is that if you've had COVID, you've probably saved yourself the cost of buying a vaccine, because nature has vaccinated you. So honestly speaking, scientifically speaking, you should not require the vaccine if you've had COVID and if you've been proven RT-PCR positive. There is a further test which is possible, which is checking your antibody levels. Though the antibody levels are a little bit iffy at this point of time, but in India, you see the problem is, so for example, you want to get the Astra vaccine in the government platform, you will probably get it for $200. But to get your antibody checked, it costs $600 or $700. So many people would just queue up and have another dose of vaccine anyway, simply because it will be more expensive to have your antibody checked. So we need to sort these things out, but truly speaking, from a scientific point of view, I think many countries, probably, the NHS and the SAGE associated, the SAGE group in United Kingdom are probably now, so far, probably they're not too keen to vaccinate people who've already had COVID, because theoretically you should not. Theoretically, you should not need it. So you save yourself some money.
So I think I think Professor Larson has to also leave for another session, and we're also out of time. A lot of questions, but this discussion can go on for hours, I think. So anyway, I'd like to thank all the spotlight speakers, Professor Heidi Larson and Mr. JBR Prasad Rao, sir, for joining us today, and Dr. Kunal Sarkar for taking time out and moderating this session. It's been a very insightful session and very apt session in recent times. Thank you so much for joining us today, ma'am and gentlemen, for joining us today.
Thank you. Thank you.
Thank you so much. Thank you so much. Thanks for
Thank you so much. Thank you.